Well, greetings everyone and welcome to the EKG case from the week of July 28th, 2014. This week's case comes to us all the way from Perth, Australia. Dr. Ben Smedley works at Rockingham Hospital in Perth, down under. You know, I kind of wonder whether the folks in Australia refer to us as up over. I don't know. If anyone down in Australia can answer that question for me, please send me an email. Up over versus down under. Anyway, so Ben is working in Rockingham Hospital in Perth, and he sent to us some other very interesting cases at least one or two times before we've actually used them. And so my thanks to Ben for sending some really great cases. Anyway, one day he was working in the emergency department, and he and his team got called to the outpatient stress test area in the hospital. So I guess whenever there's any adverse outcomes in an outpatient area, the emergency department responds to that area, not unlike many other hospitals, and sometimes we'll do the same thing as well. And invariably, the patient will come down to the emergency department. So what exactly did they get called up there for? Well, there was a 39-year-old woman who had an outpatient treadmill stress test ordered by her general practitioner. I don't know the full outpatient history, so I don't know why. But anyway, she's up there getting her stress test when, during the treadmill stress test, she developed chest pain, then palpitations, and then had a syncopal episode. Hopefully she was able to get off the treadmill before she syncopized. And she has no risk factors for coronary disease, no family history of sudden cardiac death, and we'll find out why that's important in just a second. So they arrive to the treadmill stress test area. The patient already has an AED attached, which is advising to not shock. Patient's pale, diaphoretic, she's awake, and she's gradually waking up without an apparent post-ictal period. So this appears to be true syncope. And she's taken down to the emergency department and continues to recover in the ED resuscitation area. And as Dr. Smedley and his team looked over the EKGs from during the stress test, the diagnosis became very obvious to them and hopefully to you. And they were able to do the ideal thing and essentially make sure that the patient got the proper treatment. So let's take a look at some of those EKGs. Now, this was the first EKG that was obtained, and this was at rest before the patient actually, I suppose, got on the treadmill and started exercising. Overall, there's a lot of artifact, but there's nothing really abnormal, just kind of jumping out at us. The intervals overall look pretty good, and it appears to be sinus rhythm. There's no really big ST elevation or depression. If there were, I'm sure she wouldn't have gotten on that treadmill. Anyway, pretty unremarkable. We'll come back to this in just a little bit. Now the patient starts the treadmill stress test. We're about 6 minutes into the test, and you can see that the patient's starting to develop the expected tachycardia, heart rate of 124. There's still, unfortunately, a lot of artifact here, but maybe nothing is really jumping out just yet. And then, about 10 minutes and 3 seconds into the test, the patient starts developing ventricular arrhythmias. Now, even with all the artifact, you can clearly appreciate that this is heading towards ventricular tachycardia. Heart rate's about 124, and then within a minute, the patient goes into what appears to be polymorphic ventricular tachycardia. QRSs are small, QRSs are big, QRSs are small, then they get bigger. So this appears to not just be plain old polymorphic VTAC, but it also has that torsade type of appearance. So as you recall, torsade is a type of polymorphic VTAC that tends to most often be associated with the prolonged QT. So let's go back and see if we saw a prolonged QT along the way. And here's the initial EKG when the patient started the treadmill, and it's kind of tough to see what the QT is when somebody's tachycardic. Looking at the baseline 12 lead, even at the baseline, the QTC appears to be pretty much normal if you use the machine's numbers. And again, if you use that eyeball method that we talked about a week ago, let's take two QRS complexes. Let's take these, and we'll go right halfway between the two QRS complexes. And it looks like that T wave is ending right at about the halfway point or just before. So overall, I'd have to say this is a pretty normal QT interval. So it's a bit unusual that the patient would have developed polymorphic ventricular tachycardia of the torsade type. But anyway, that's kind of what it looks like. Polymorphic VTAC at the very least. Whether it's torsade or not, we'll have to try to figure out what happens. Anyway, the patient went down to the ED resuscitation area and gradually got better. They got a repeat 12-lead EKG by this point after the patient's waking up. And now maybe you're starting to appreciate a little bit of an abnormality here that we've talked about quite some time ago. Hit the pause button if you need to, but take a good long look at this EKG, because this is something that is definitely something that you've got to know. Everybody in acute care medicine, emergency medicine, has to be able to pick this up. Now, the EKG machine's helping you out a little bit. It's calling there an incomplete right bundle branch block pattern, but that's not all. If you look in leads V1 and V2, you've got that incomplete right bundle type of pattern, and there's ST segment elevation. And then we get another EKG a short time later, and there it is. Now the patient's fairly asymptomatic. There's an incomplete right bundle pattern in V1 and V2 with T-wave inversions. I'd say actually this EKG is even more obvious. Incomplete right bundle with ST elevation heading into flip T-waves in leads V1 and V2, and of course you know what the diagnosis is. The patient's diagnosis here is Brugada syndrome. It's been a little while since we talked about Brugada, and what's nice about this is that the patient doesn't even need an EP test because the patient demonstrated the arrhythmia during the stress test. Anyway, for those people that are not familiar with Brugada syndrome, just a quick recap, and I'll tell you up front that this week is part 1 of Brugada. Next week, we're going to do some updates on Brugada. So this is Brugada part 1 this week. This is an electrical phenomenon first described in the early 1990s by a couple of cardiologists who were brothers, Pedro and Josep Brugada. They went down to Southeast Asia to investigate a disease that was responsible for the death of a lot of young adolescent males, who oftentimes would die suddenly in their sleep without any specific provocation. And they were the first people to describe this Brugada syndrome. It is an electrical phenomenon, therefore they had these patients that even at autopsy had completely normal, structurally normal hearts. It's considered hereditary, although not everybody in the family is going to have the genetic abnormality. Or the other important point is to remember that not everybody is going to tell you that there's any family history of sudden cardiac death. So you can't always rule this out just because somebody has no family history. Now, how common is this? Well, according to some international literature, it is estimated that this may be responsible for 1 out of every 5 sudden cardiac arrests in patients without structural heart abnormalities, and it may be responsible for as many as 4 to 5% of all sudden cardiac deaths. Amazing. This is more common than we ever realized. And up until 1992, before it was described, we were missing this over and over and over. And I'm sure that there's still many cases that are still being missed because word hasn't gotten out enough about Brugada syndrome. Although this was first described in Southeast Asian adolescent boys, it has now been identified pretty much in every country and every ethnic group, and men and women, and the average age of diagnosis that we now know is average age of around 40. Now recall that this woman in the case was 39 years old. It's a bit unclear why patients can go 5, 10, 20, 30, 40, 50 years without any problems and then suddenly hit a certain age and then they start having problems of syncope or episodes of polymorphic VTAC, sudden death, and so on. People are still trying to figure that out. What is it that sets it off at a certain age? But average age is not adolescence. Average age, we now know, is around 40 years old, just like the woman who presented in the case here. Now, when I previously talked about Brugada syndrome in the past, I had quoted some literature that indicated that once symptoms develop, the mortality may be as high as 10% per year. Now, there are some updates to that you'll have to listen to next week regarding the mortality statistics. What still seems to be true is that placement of an internal cardioverter defibrillator is still the best therapy, perhaps the only effective therapy. Antiarrhythmics in general do not affect the prognosis and in general do not work that well. There may be some rare exceptions that are talked about in the literature, but for the most part, the treatment is get them to an electrophysiologist for confirmatory testing that we'll talk about, and they will place an ICD in these patients, and the mortality drops to near zero. The placement of an ICD is life-saving in these patients. Now, what is it that you and I need to look for on the 12-lead EKG? Well, they first described abnormalities in leads V1, V2, V3, and I'm going to change that because when you actually look at the literature and the cases I've come across and cases that people have sent me, I would say V1 and V2 are your money leads. Forget about V3. V1 and V2 are the leads that you've got to look at. We'll cover those in just a second. And these patients are predisposed to develop polymorphic ventricular tachycardia, and it can look like torsade, even though the electrolytes are oftentimes normal, even though the QT interval can be normal. They oftentimes do have a torsade type of appearance. In less common circumstances, they can develop monomorphic VTAC, but more often polymorphic VTAC. Now, when these patients develop the VTAC, one of two things can happen. They can either degenerate into ventricular fibrillation, and that's what we call sudden death, right? Or if they're lucky, it spontaneously terminates. And those patients will wake up and they'll present with syncope. And that's exactly what happened in this case. Somebody from above was looking out for this patient, and instead of degenerating into VFib and dying, she ended up having spontaneous termination of the arrhythmia, and she woke up, and it was just a plain old syncope episode. So you see, sudden death and syncope oftentimes are caused by the same disease, just along a spectrum, depending on how lucky that patient is. Once again, structurally normal hearts, family history may be in only about half the patients, so don't ever rule this out just because there's no family history. All right, EKG. What exactly are we going to look for in leads V1 and V2? What we're going to look for is a right bundle, or perhaps more commonly an incomplete right bundle pattern in V1 and V2 with ST segment elevation. The elevation can come in two types. There's a cove type, which is convex upwards. There's a saddle type, which is concave upwards. And we'll show you some examples of what we're talking about. Here we go, the saddle type. So here you see an incomplete right bundle type of pattern in either of these leads, V1, V2, and the ST elevation is concave upwards. What is more common, more sensitive, and more specific is a cove type. There's ST segment elevation of a convex upwards, or sometimes it's straight, and it terminates into an inverted T wave. This coved pattern, the convex upwards with inverted T wave, is more sensitive, more specific, and a lot of electrophysiologists, when they see that pattern in somebody after a syncopal episode, they don't even feel obligated to do the EP test. They just go right to placing an ICD. The saddle morphology is kind of falling off in terms of sensitivity and specificity, and I'll give you more details about that next week. All right, so once again, you're going to see an incomplete right bundle, let me see if I can get this right, incomplete right bundle type of pattern with a cove type of morphology, or you might see an incomplete right bundle pattern with a saddle type of morphology. And I should have probably have drawn an inverted T wave up here. This is the more concerning type of morphology, more concerning than this morphology. All right, so coved and saddle. All right, two morphologies. When you see this, contact your electrophysiologist for confirmatory testing. Back to the case. Patient was stabilized and went right for an AICD. And last I heard, the patient seems to be doing well. All right. So once again, today was part 1 on Brugada. Next week, we're going to talk about some updates based on some recent articles that have been published. But let's go over some take-home points from today. Key point number 1. Anytime somebody comes in with a syncopal episode, and you look at that 12-lead EKG, what are you looking for? We've talked about this before, but I'll say it again. Everybody always remembers to look for ischemia. Everyone always remembers to look for tachy and Brady dysrhythmias. Always make sure that Brugada is on the list of things that you look for in every patient presenting with syncope. Otherwise, you miss it. And these are usually young people who, if you make the diagnosis, they've got great outcomes. If you miss the diagnosis, they have a strong chance of going on to die. What are you looking for in the 12-lead EKG? Incomplete or complete right bundle pattern. I think incomplete's probably more common. Your money leads are V1 and V2, and you're going to see ST elevation in those leads. Now remember, normally with an incomplete or complete right bundle in V1 and V2, normally there's ST depression. So if you ever see ST elevation in the presence of that right bundle or incomplete right bundle, that should really stand out as abnormal. And especially look for this in those people that come in after syncope. And the coved ST segment elevation, the convex upwards ST segment elevation is really what you worry the most about. When in doubt, or when you have a suspicion, get on the phone with an electrophysiologist. My experience, as I've said in many conferences before, even at our own hospital, is that the electrophysiologists are the cardiologists that know about this. They live for this. They love talking about it. Those are the ones to get on the phone with if you have a choice. If you contact a general cardiologist, an invasive cardiologist, I can't guarantee, I'm not sure there's any guarantees that they will know about this condition. They certainly won't know as much as the electrophysiologist. So whenever possible, get on the phone with the electrophysiology folks. They are the ones who are going to take care of this, and they live for this. So I hope that was helpful. Again, stay tuned next week. Next week, we'll do part 2 of Brugada with some updates, and also we'll talk about, and I'll show you a whole bunch of Brugada cases that have been sent to me over the past year and a half or so that I've been procrastinating on showing. But there's at least a half dozen fantastic Brugada cases that you all have sent, and we're going to highlight those on next week's part 2 Brugada case. All right, so I hope that was helpful, and my thanks once again to Ben Smedley for sending a great case. I look forward to talking to all of you next week. Bye for now.